This is Dr. Andrew Young at USC Orthopaedics, and in this video, we're going to explain how we diagnose and treat osteonecrosis. Osteonecrosis is a condition in which blood supply to the femoral head is interrupted, and in the absence of oxygen and nutrients, the bone cells in the hip die, and then the dome of the hip collapses and weakens. This can occur in one hip, it can occur in both hips, it can occur in older and younger patients. Common contributors include prolonged steroid use, heavy alcohol use, prior trauma, fractures, blood disorders. When both hips hurt, when we have bilateral disease, daily activities become overwhelming and very difficult. Our goal in this video is to show a careful, stepwise plan that restores comfort, alignment, and function with hip replacement. We'll cover how we diagnose the problem, how we plan the surgery, why we stage hips one at a time, and how we aim for symmetry so both sides work together. So osteonecrosis represents a continuum of change, and it progresses from early changes to later stages of collapse as seen here. In early stages, the femoral head is still round, and the MRI can show changes that we can't see on X-ray. However, as the disease advances, X-rays will begin to show signs of sclerosis and bone hardening, and cysts, which are both signs of bone trying and then failing to repair itself. And the key question for treatment is to determine whether the femoral head remains spherical or if it's lost its round shape. Once it's lost its shape, once it's collapsed, the smooth ball will flatten and the cartilage surface is no longer congruent with the socket. We make these determination by first studying the front view. This is called the anterior posterior pelvis, or the front view. And this assesses the overall shape and joint space. And then we'll use the lateral side to confirm the extent of collapse. The lateral view in this clearly shows collapse of the weight-bearing dome. In early stages, a classic sign is the crescent sign. In this later stage, we can actually see collapse of the cortex. We follow this line up here, and then we see this drop off. All this bone is necrotic in the weight-bearing portion. Therefore, the load path from the acetabulum to the femur is interrupted. And this explains the sharp pain with weight-bearing, the limp, and the weakness. These images, especially the lateral, help us decide whether joint-preserving options are still reasonable, like a core decompression, or whether there is now collapse and a replacement instead is required. When we see collapse, total hip replacement is the most reliable way to restore function. And for safety, we perform hip replacements one at a time. So even if there is bilateral necrosis, we will do one side at a time to reduce the amount of physiologic stress on the body, the amount of blood loss, and the clot risk. This also allows the first side to recover before the second side is addressed. And we typically begin with the side that bothers the patient the most. And in this situation, the patient has told us that the left side bothers her more than the right side. We then go to the operating room and begin with preoperative templating for precision. We obtain a calibrated radiograph with a known marker to correct magnification, and then we level our pelvis so our measurements are true. We plan the center of rotation and cup size, and then we plan a femoral stem that will sit straight down the canal for a secure fit fill. During surgery, we'll remove the femoral head that is necrotic and then confirm what our imaging has suggested. Here we see healthy bone at the periphery, but a central region of necrotic collapsed bone beneath the cartilage. This is where we saw the cortex and then the drop-off on that lateral film. Because this scaffolding has failed, the joint cannot carry normal body weight without pain. We'll then go on after this is removed to prepare the acetabulum for an ingrowth shell, and on the femoral side, we'll prepare the canal for a stem that achieves solid primary stability. Our preoperative row mat, following the template, we reconstruct the first hip. The acetabular cup is positioned at the appropriate inclination and version with a polyethylene liner inserted. The femoral stem is aligned neutrally in the canal with good cortical support. This combination restores a smooth ball and socket with the center of rotation returned to its natural location. Generally, recovery on this first side will take 2 to 3 months. Patients will start walking on the day of surgery with full weight bearing. Pain control is multimodal. Physical therapy will focus on gait training, transfers, and early strengthening. When strength, balance, and confidence have returned, we will start scheduling the second side. Repeat the measures on the second side. We obtain a calibrated image with a neutral pelvis, and the first hip will provide a reliable roadmap for the second side. We'll confirm sizes, angles, center of rotation, offset, and hip length. We'll often use the same implants on this side that we used on the other side to achieve balance and symmetry. And the usual interval between these is between 8 to 12 weeks, which is tailored to the patient medical status and goals. During surgery, we'll use enabling technology to make sure that our components are appropriately sized, seated, and positioned. In this image, we are implanting the acetabular component. We're making sure that it's appropriately seated to the level of the bone, that it's in the proper abduction with the proper amount of version. In this next view, the acetabulum is already seated, and now we have placed the trial-femoral component. We will then confirm hip lengths and offset by observing soft tissue tension and muscle function. We will test stability through a range of motion to make sure there's no impingement. And then we look at hip length and offset by, again, finding a neutral pelvis, putting the legs in the same position with the same rotation, and comparing the symmetry on both sides. Once we measure that qualitatively, we'll then measure this through our computer software. We will first draw a vertical line through the midline from the sacrum to the pubic symphysis, and then a perpendicular reference line across the base of the teardrops. From that line, we will draw perpendiculars to the lesser trochanter on both sides. And in this case, we could see each side measures 35 millimeters, which confirms balanced hip lengths on both sides. We also confirm that the center of rotation on each side is at a similar height and that the femoral offset is restored. In summary, bilateral necrosis can be a painful, challenging, overwhelming situation, but a structured approach can help a patient restore pain, function, and quality of life. Staging the hips, doing one side, then the other, limits the risk and allows recovery between the two sides. Templating allows us to achieve symmetric and precise positioning of components and alignment. Most patients return to walking with progressively fewer aids over several weeks. Then they'll be able to resume low impact activities, then recreational and competitive activities as they gain confidence and strength. These modern implants are designed for durability, and then we expect this patient to go on and live an active, healthy, comfortable life. Thank you very much.